to play, as well as just how effective surgery is. A lot of the papers mentioned that Wilfred in the last presentation were of low BMIs, admittedly, but between 30 and 35, rather than right down. And he showed some figures, obviously right down to BMIs of 25, which look impressive. So I'm going to have a disclosure here. My disclosure is that my BMI is 27.5. Would you operate on me if I had type 2 diabetes? Or would you perhaps look at one of my colleagues, both of them are here, whose BMIs are much lower than even mine? So the question is, why surgery when medical treatment is good? Well, Wilfred tried to show that medical treatment wasn't so good in the long term. But then again, surgery in the long term isn't necessarily quite as good as that. It's been shown that if you take surgery in type 2 diabetes, there is a recidivism rate. Is there a demographic difference? And this is where we come into whether the Asian group and in the Asia-Pacific area is different. And there's difference between insulin-dependent and non-insulin-dependent diabetics. And what are the advantages of medical treatment? And what people haven't spoken about is what are the risks of surgery. So obviously type 2 diabetes, very simply, is increase in sugar levels and HbA1c and the so-called causes of insulin resistance and beta cell function. Why surgery when medical treatment is good? Diet and weight loss, life changes, and it's been shown that there are life and physical changes like exercise and things, reduce HbA1c. Resistance training is another factor there. And if you take low glycemic index foods, it'll happen. The medications that are available, and you can see that it's not easy to see, but there are a list of number of different medications, and they've been tried, and there are the new ones. There's the metformins and the thioglycosides, the new ones of Actos and Glycet, and the injectable medications of GLP-1 agonists and like Byetta and Victoza. So there is a lot of medication available for the treatment of type 2 diabetes. And so what are the advantages of medical treatment? Well, it's not invasive, and this is one thing we as surgeons have to take in consideration of our complication rates. The cost, well, there's an argument about cost in the long term, but in the short term, certainly the cost of medication is much less than the cost of surgery. Lower risk, less side effects, and what's more, they can be treated by their local medical officer or specialist in a nearby location. They don't have to come to a surgical centre for follow-up. And also, there can be some degree of self-regulation with phone instruction. And there are a wide range of choices. But this is just what I want to show you. A 10% loss of body weight will give significant improvement in type 2 diabetes. And that's been shown. I think the Australian Diabetic Association said even a 5% loss of body weight will just about not quite get rid of type 2 diabetes, but nearly, but 10% will. And what I wanted to show you here was that if at a BMI of 27.5, your 8 kilograms equals 10%. In other words, a 10% loss will give you a BMI of 24.89. So you'll come into the normal range with just an 8 kilogram loss. Is it that difficult if you're a type 2 diabetic to lose 8 kilograms conservatively? And what about 4 kilograms, which equates to 5% of body weight? So this shows you that at a BMI of 27.5, all you're talking about is a very little loss of weight in order to get a very good outcome in relation to type 2 diabetes. And therefore, what are the risks of surgery? Well, we all know the risks of surgery. We've all had complications from this. The mortality is one, the renal problems, the perforations and leaks from all these procedures that we do. We can get slippages from bands, erosions, and 10% of bands don't lose weight. In fact, one of my colleagues was telling me today that he's got patients with gastric bypass that don't lose weight at all. So you have to take into consideration the success rate of surgery as against the risk factors as well. So David Cummings actually at the last meeting, and I'm these are some of his slides I'm going to show you, the incretin effect. So if we can use the incretins as agents, medical agents, to help there. Basically, as you know, the definition of an incretin is a hormone during absorption, and the effects on glucose. The GLP-1 and GIP are two of the main ones. The effect of GLP-1, as you know, is, and this is John Dixon's slide, has an effect on all tissues, particularly in relation to satiety and beta cell effect and insulin sensitivity. So you've got these, as you know, this has been shown before today about that, and the effect of incretins in type 2 diabetes. In type 2 diabetes, you get a mild impairment of GLP secretion, an impairment of a GIP action to stimulate the insulin secretion. So, and this is the theory as to why it occurs, and again, the impact on beta cells, and people have shown this as well, and the metabolism of GLP-1 by DPP antagonists. So this is the effect there. So impairment of beta cell function and deterioration of glycemic control in type 2 diabetes occurs. So there's an algorithm that he talked about where if you gave GLP-1 agonists like Byetta or Victoza, then you'd get a beneficial effect. And we're only looking for between a 4 and 8 kilogram loss, in order to get the beneficial effect. Now, in relation to the demographics, why the Asian group as compared to the, say, Caucasian group as well? Well, the Harvard School of Public Health did a study. They said that the Asian increased body fat is only 3 to 5% of the Europeans, particularly in South Asia. In blacks in America, they've got less body fat than whites, but they've got more lean body mass, but obesity is higher in that particular group. The genetic differences are in the case of different fat patterns in Asia, but environmental factors are a much stronger force. If you have undernutrition in fetal life, and they gave an example of the Chinese famine of 1954 to 64, with an increase of type 2 diabetes in adulthood, especially if more nutritionally rich environment later. In other words, if you've had nutritional deficit when you're very young as a baby, etc., and you come into a nutritionally rich situation, you actually get a better chance of developing type 2 diabetes. So in conclusion, my argument is no surgery for type 2 diabetes under 27.5. The medical treatment includes lifestyle and environmental changes and will reduce the effects of type 2 diabetes without the surgical risks. Thank you.
Thank you very much, Dr. Harry. Now we have heard strong arguments both against and for the surgery in BMI less than 27.5. But we surgeons would be trigger happy. So the next debate is on surgery for low BMI diabetics. Our first speaker, Dr. Suren Ugale, is not able to make it. So we'll go on with the second talk, and that is by Dr. Kazama, and he'll be talking on DJB, sleeve DJB.
So thank you, Murphy, for giving me an opportunity to talk about the DJB plus sleeve. And it is really my honor to have a debate with my mentor, Ricardo Cohen from Brazil. I actually learned bariatric surgery from Ricardo 10 years ago, so that he's a mentor of my bariatric surgery, and he's one of my best friends in Brazil. So that it's really my honor to have a debate here. So that this time, I'd like to talk about the DJB plus sleeve. So the classical DJB was championed by Ricardo Cohen, and I think it's a possible surgery, but not as good as expected. And long-term data was lack, and complication regarding ulcer and delayed emptying of stomach, that will cause the vomiting a lot. And the DJB with sleeve was just a modification of BPDDS, and it was reported in 2009, and it's just a combination of the sleeve gastrectomy and the gastric bypass. As you know, that result of sleeve gastrectomy is very good, and also the result of gastric bypass is very nice. So that I thought that the combination of both of them must be very good. And why DJB in comparison with BPDDS? So that DJB with sleeve is just a longer common rib over the BPDDS. So that we think that less malnutrition, especially for Asian. You know that the total amount of protein intake for Asian was much less than that of the Caucasians. So that malnutrition risk with BPDDS is higher in Asian population. And smaller pouch than BPDDS, and we can change the size of sleeve according to BMI. So why DJB in comparison with gastric bypass? So no bypass stomach and preserving the pyloric ring. I believe less ulcer and less stenosis of anastomosis and less dumping. So why DJB with sleeve in comparison with sleeve alone? Of course, it's adding a bypass effect, so that the better outcome for type 2 diabetes. So for Asian diabetes, we have a very nice meeting which is called the Asian Diabetes Surgery Summit. So that was led by Dr. Wei-Jie Lee, and for the Asian low BMI patient with type 2 diabetes. So this is the table from the ADSS meeting of this year, and this is very nice data, but one thing is wrong. So Wei-Jie, YMC Japan and the Ryotsu Medical Cube Japan is the same institute. The other thing is fine. And this is a result of DM remission within 2 years. So as you see here, the DJB plus sleeve is a bit better than the other procedures. So I'd like to talk about the result of my DJB with sleeve. 124 patients of Japanese underwent sleeve with DJB, and 89 patients per follow-up over 1 year, and 75 out of 89% patients were with type 2 diabetes before operation. Of course, the IGT is not included here. And the patient characteristics is like this, and the BMI was, average BMI was 39.6, and 22 patients with BMI under 35. I will talk about later the detail of the lower BMI patient. So this is the status of diabetes. The 48% of patients of my sleeve DJB had insulin injection before surgery. The duration of type 2 diabetes 9.2 years. So that from now on, I'd like to use a definition of the remission of diabetes according to the ADA guideline. The partial remission is the hemoglobin A1C less than 6.5%, and the complete remission, the hemoglobin A1C less than 6% with no diabetes medication at 1 year. So this is the result of all of my sleeve DJB. Follow-up rate is around 90%, and complete remission is 90%, 70%, and partial remission is 13%, and both of them are 84%. And 93% can achieve hemoglobin A1C less than 9% with or without medication. That is one of the goals of the treatment of diabetes. And so for the composite endpoint, we can achieve 31% of the patient after surgery. So we have to know how severe each diabetes is. So that I use the ABCD score, just the Wei-Jie talked about that. So this is a modified ABCD score, and which Wei-Jie and Dr. Dixon made. And this is distribution of patient based on the ABCD score. So in my sleeve DJB patient, we have a lot of severe group. So this is a comparison between remission and non-remission groups after my DJB, sleeve DJB. As you can see here, is there a pointer here? No. Is there a pointer? No. So BMI at the baseline and the excess weight at baseline, and the C-peptide at the baseline, and the duration of diabetes and the insulin number, percent of insulin user are different. And the weight loss at 1 year and also insulin and home IR are different. The other has no significant difference. But this is a multivariated analysis of the multiple logistic regression. Only modified ABCD score was significantly different at the 1 year after surgery. And this is a comparison of remission rate according to ABCD score regarding sleeve gastrectomy, sleeve DJB, and lower gastric bypass. Blue one is lower gastric bypass, and green one is sleeve DJB. As you can see here, according to the ABCD score, sleeve DJB is a little bit better than that of lower gastric bypass. So this is a pre-op C-peptide level at 1 year after sleeve DJB. And you can see here, even in the C-peptide less than 3, the complete remission, the partial remission rate is around 70%. And also, this is a diabetes duration. And as you can see here, the duration over 10 years is remission rate is around 56%. Not as good as the others, but not too bad. And this is the pre-op BMI. Of course, the remission rate is lower in the low BMI group. So I'd like to focus on the lower BMI patient, the BMI less than 35, and 25 out of 38 patients were followed up at least 1 year. Of course, IGT are not included. This is the characteristics, and average BMI is 32.2, and average weight is around 90 kilograms. And the duration of type 2 diabetes is 9.5 years average, and 64% of patients use insulin before surgery. So this is a distribution of the patient based on the modified ABCD score. As you can see here, the lower BMI patient has more severer than the others. And this is a result of a 1 year follow-up. The follow-up rate is 92%, and the remission rate is 61%. And compared to the old patient, it's quite less. But hemoglobin A1C less than 7% with or without medication is 94%. It's not bad, that this kind of patient could not have a very nice control before surgery, but after surgery, they can have a very nice control. And this is a result of 1 year, the sleeve DJB for low BMI patient. As you can see, these parameters are all significantly different. So that, but the comparison between the remission and non-remission group for the low BMI patient, only a duration of diabetes and the modified ABCD score were significantly different in the remission group and non-remission group. But I'd like to say that for the urine analysis, even in the lower BMI patient, the surgery can improve the renal damages. So that before surgery, many patients have a urine protein positive, but after surgery, many patients become the urine protein negative. This is a remission rate of DJB plus 3 for lower BMI patients according to the modified ABCD score. So this is a complete remission rate of 3 with DJB, and this is a remission rate of 3 with DJB. And as you can see here, the remission rate of 3 with DJB is not so bad. So this is a comparison, and this is a figure. The blue one is the lower gastric bypass, and the green one is 3 with DJB for all patients. And light green one is a sleep with DJB for lower BMI patient. As you can see here, of course, that all patient is better than the lower BMI patient, but remission rate of lower BMI patient is also not bad compared to Roux-en-Y gastric bypass. So this is the conclusion. Modified ABCD score is useful and the only independent factor to predict the remission of type 2 diabetes after surgery. Response to the surgery for the diabetes patient with BMI less than 35 is not as good as that of BMI over 35. But I still think that DJB plus SIRB is an acceptable option for Asian type 2 diabetes with BMI less than 35. And it's especially for the patient in the country with a high risk of gastric cancer. Thank you very much.
Thank you, Dr. Kazama. Now we again welcome Dr. Ricardo Cohen, and he'll be talking in favor of Roux-en-Y gastric bypass in low BMI diabetics.
I want to thank Kasama for his kind words. And actually, I don't know if it's a debate between the Roux-en-Y gastric bypass or sleeve DJB, because I was speaking to Luigi. I've run a randomized control trial. We're finishing the follow-up, and the results over metabolic control are quite the same. But the sleeve DJB has it's a tougher operation. It's worse to do it, and well, the Roux-en-Y gastric bypass, in our experience at least, has the same results. So it's a debate to be followed, and we're starting publishing our results. We're gonna soon. So what's going on? No, I can do it here. Detect this place. Not detecting. Okay, but it's the same thing here. If you detect this place, it's the same thing. It should be there. It should be there. So I think it's a major debate, maybe a debate with ileal transposition. We could go ahead, because I believe the ileal transposition is a good model for studying the physiology of the operation, but I don't think that the operation is worthwhile the outcomes. But why do we need to address the low BMI patients? Because I believe that the endpoints in diabetes are not reached, and more than 50% of diabetics in the world, this includes, of course, the Asia-Pacific region, but in the United States, for example, the mean BMI of diabetics is 31. In Brazil, it's 28.6. In Chile, it's 27 point something. So the vast majority of patients are not covered, because the morbidly obese patients, we have around 15 to 18% of diabetics in the morbidly obese population. So we're not addressing the real population in the world. And as we repeated ourselves in the last talks, BMI is not accurate, and I think assessing the cardiovascular risk is the most important thing. And I believe that the non-alcoholic steatohepatitis, NASH, is one of the most important markers of diabetes, uncontrolled diabetes. So I think we should start learning other things, not only the metrics, but assessing cardiovascular risk, the carotidial intima, resilient blood pressure, LDL, triglyceride. We had a lot of things to put on with BMI. And we know that BMI is discriminatory to gender, the fat distribution, age, fitness status. If you, Mike Tyson during the 80s had a BMI of 38, and we did not operate them. So fitness status is it's a prejudice against fitness status and the severity of comorbidities. It does not predict the success of any treatment. If John will give them GLP-1 analogs or DP4 inhibitors or glidazones or metformin, the BMI by itself does not predict remission or success of treatment. And BMI alone does not predict at all cardiovascular deaths or even events. And this is not my opinion. Look, this was a picture at the European Association for the Study of Diabetes last year in Berlin. Look at those. This graph it's impressive. This is a medical meeting. It's not a surgical one. So this is diabetes in the world, diagnosed diabetes, receiving care, and achieved outcomes. Look at the difference. Diabetes is not under control at all. And the same came from the United States. If you look at the 3 endpoints, A1C below 7, blood pressure, LDL, it's around 50% of control of A1C, blood pressure, and LDL by themselves alone. And the 3 endpoints is less than 20%. So the world, this is a mirror of the world probably. The world do not control diabetes. Less than 18% have all the 3 cardiovascular factors under control. So it's clear that diabetes is not under control at all. Even with the improved medications, even with everything that has been done for diabetes. So we're promoting the case for Roux-en-Y gastric bypass, and I'll do for sleeve DJB as well, because as I mentioned, we ran a randomized control trials and the results are the same. And I like the gastric cancer issue that Kasama raised. And why Roux-en-Y gastric bypass? It has history. It's the oldest operation used for a long time. It's durable. You have long-term follow-up with good results. It's safe, low mortality, less than 0.3% of mortality in experienced hands. It's reproducible. I bet that if I do a gastric bypass, it's the same as Shashank, it's the same as Harry, it's the same. All over the world, we have the same results. And that's different than bending or sleeve. It's different. If you look at the sleeves in Michel's presentations, he has excellent results. If you look for other people, the results are not that good. And we have efficacy proven and high and durable diabetes resolution rate. And although we know a small fraction of the mechanisms, the bypass is the operation who provides most of all of the information. And gastric bypass was for low BMIs was presented for those authors. Actually, Malphobia, I think Luigi presented his data. It's non-diabetics for statistical purposes only. But I'm going to touch some points and start with the most diabetes susceptible populations. That makes sense in India. Look at this is a classical picture. This is the same BMI, and look at the difference in body fat distribution. So this happens in India. And Asian Indians are vulnerable for developing diabetes. It's a higher percentage of body fat in a given body weight, a preferential visceral fat distribution, and there's some genetic predispositions to higher insulin resistance, a decreased beta cell function volume, and a decreased glucose-mediated insulin secretion. So there's a decreased incretin function. And the cardiovascular risk, the metabolic risk in Asian Indians is much higher than European Caucasians, for example, in this paper. So Shashank Shah, I think he was here, the audience. He published back in 2010, patients from 22 to 36, they overweight to obese according to the World Health Organization criteria. They had type 2 diabetes confirmed with antibodies, C-peptide, and family history. They were severe mean duration of diabetes of 9 years. 80% of them were on insulin, and they were glucotoxic, A1C of 10.1 at baseline. And most of them were dyslipidemic, and 60% of them were bearing hypertension. At 9 months, the results published in SWORD decreased at 20% in BMI. Hypertension improved and close to 70% decreased their medication. And dyslipidemia improved and 100% discontinued medication by the 9th month. They had 100% of patients decreasing their fasting blood glucose, and by the 9 month, 100% of them were off all of diabetic medications. The same A1C that dropped from 10.1 to 6.1. Again, of course, at 9% and 9 months, all of them were without medications. They plotted their data in the UK PDS risk engine. It's a math model. It's on the internet, UK PDS website. And there's a significant decrease in coronary artery disease, fatal and non-fatal, and the same thing in fatal and non-fatal stroke. So it presumably decreased cardiovascular risk predictions at 10 years. The bottom line is 100% of the patients had remission of diabetes at 3 months. It's at more than 2 years follow-up, and the results still persist. They lost 20% of the total body weight, and it's better than expected for severe obesity. Murphy published, and he showed his results, published in SWORD this year. Remission is A1C below 7 for more than 6 months, and they had 60% of A1C below 7% at 5 years. And it's interesting, the 3 endpoints would reach 96.2% at 5 years. Remember the ADA paper that was published in February this year that I showed? Less than 20% versus 96.2% of the 3 endpoint reached at 5 years. So we did the same thing in our gastric bypass in our Caucasian population. We have 66 patients. Median follow-up is 5 years. We had 2/3 of them followed at 6 years. 30 to 35 in Brazil is mild obesity for our population. We confirm severe diabetes, 13 years of mean durations for 2 to 20 years of diabetes were selected in this trial. 40% were on insulin, the rest were on oral medications. They were glucotoxic as well. A1C was 9.7 at start. In our trial, C-peptide was not a predictive factor at all. If it's over 1, it doesn't make any difference in a long-term run. And in glucotoxic patients, there are fantastic papers published last year about the differentiation of the beta cell. The beta cell under gluco and lipotoxic stress, they are in disguise and they start producing glucagon. So I don't think that the C-peptide alone by itself in glucotoxic population will be a strong marker of prediction of diabetes remission. So this is a long debate, and I think we should eventually start debating this later on. We have a very nice decrease in A1C up to 6 years. The same happened with the fasting plasma glucose. We define remission patient with A1C below 6.5 with no medication, a partial remission or improvement, A1C below 6.5, then less medication than baseline. There's no correlation of, again, in this, of BMI, the variation, the delta BMI versus the delta glycemia in our regression analysis. What we did, we studied all of the follow-up points. And again, at 6 months, there is no correlation at all of change of BMI and A1C. The same happened in fasting plasma glucose. At 1 year, fasting A1C and fasting plasma glucose. And again here, and I showed previously, by the 6th month, most of the patients were resolved. So there was no relation between weight loss and improved glycemia in our cohort. The effects on insulin secretion. We did a standardized meal test post-op, and we compared the earliest versus the latest follow-up comparing C-peptide secretion. And we had close to 500% of increase of beta cell sensitivity to glucose if we compare the earliest to the latest post-op follow-up. And the effects on insulin sensitivity, it's roughly measured by a surrogate marker of hepatic insulin sensitivity, that's the HOMA, and there is a very nice and persistent decrease of HOMA over the years. The effects of baseline diabetes duration from 2 to 20 years. So we split this into tertiles of diabetes duration. And surprisingly, if we divide 5 years, 10 years, and 15 years, there's no change. So the change in A1C versus diabetes duration for 2 to 15 years, there's no correlation. The same happens in fasting plasma glucose in the 3 tertiles of diabetes duration. So it's probably the Caucasian population may have some genetical factors that it's different than the Asian Pacific population. and the effects on metabolic syndrome and the predictive cardiovascular disease risk. So systolic and diastolic blood pressure has had a very nice decrease. The same happened with total cholesterol and LDL. And there's no significant increase of AGL. Although there's an absolute increase versus baseline, there's no statistical difference. We did the same thing. We plotted our information in the UK PDS cardiovascular risk engine, and there is a relative risk, cardiovascular risk reduction in coronary heart disease, fatal and non-fatal, stroke, fatal and non-fatal. David Arterburn paper that John just showed us in his talk, that we had 9 years of diabetes remission. If you think on the UK PDS trial and its legacy effect, they had control in 2 years of diabetes. They controlled diabetes over 2 years, and they had a long-term decreased cardiovascular death risk index. So if within 2 years we had a legacy effect of 10 years, so 1 or 8, if we had a math thing, we're going to have a forever risk reduction. So I think this is a surrogate marker. It's this prediction in engines. We need a very big, large trial to compare medical treatment versus surgical treatment regarding real hard points on cardiovascular events and deaths. What we did is we compared. Actually, who did this was Dr. Valderos from Chile that works with Camilo. The STENO2 trial is the model of multifactorial target and follow-up and drug treatment. What we did in the intensive group here, the STENO2 intensive trial is focusing glucose, lipids, and blood pressure. So he compared, actually, he gave me this table ready to present. Look at our trial and the STENO2 trial, intensive follow-up, intensive treatment. They follow for 8 years, we follow up them for 6 years. So our results, 8 years versus 6 years, we're much better achieving remission of diabetes regarding the 3 endpoints: glucose, hypertension, and lipids. But what was more interesting, he correlated the composite index of cardiovascular risk, the cardiovascular outcomes. And if we compare what they had and we compare what we expected in our trial and we observed in 6 years, we are in much better shape than the intensive medical control. So again, this is a surrogate marker of improved and decreased cardiovascular factors, death and events with surgery, gastric bypass versus the best medical treatment focused in the 3 endpoints. Is it safe to do a gastric bypass in a patient with 30 to 35? Well, we compared this with the lab study. It's the model study for complications, and major complications and death after bariatric surgery. Mortality, we had 0 in our study, 0.2 in the lab study. Major morbidity, 4 to 5%. We had 0. It's a very small cohort. It's 66 patients only. And we had similar minor morbidity than the lab study. And we were worried, are those patients with gastric bypass, long-term follow-up, had excessive weight loss? No excessive weight loss. The minimum BMI is 23. So we don't have the risk of achieving a very low BMI in this operation. So I have to conclude that the Roux-en-Y gastric bypass is well known, is more known than the sleeve DJB, although I'm a proponent of sleeve DJB as well, so it's a weird debate. It's safe, show you the data. It's effective long-term treatment for type 2 diabetes in patients with only mild obesity. Thank you.
Thank you, Dr. Cohen. Now we go on to the next option of endoluminal solutions for weight loss and type 2 surgeries by Dr. Jan W. Grieve.
Good afternoon. It's just a little more time for lunch. We have a panel discussion after this one, but of course I'd like to thank Mufti Lakdawala for inviting me here in this really beautiful place, and I hope to be able to see a little bit, but we have a very tight program, as I've seen in the program. Endoluminal solutions. Of course, looking for less invasive and less risky procedures, that is probably a way to go. These are my disclosures. And we all know that there have been many attempts to mimic the bariatric procedures endoscopically, but also specific intragastric devices like balloons, and I'll just address a few of them to show what we know at this moment in terms of treatment of diabetes. Well, the balloon has been there for a long time, different types, maximum treatment period of half a year to 1 year. You can repeat the treatment, but there is no real long-term follow-up of these patients. Just some examples: the fluid-filled balloons from Allergan, the air-filled balloons from Helioscope, and they are getting better and better. You now have also the adjustable balloons, the SPAT balloon, the double lumen balloons, and I think that the results have improved over time. But the disadvantage is, of course, that they are short duration of treatment. And there's really very little information on the effect on metabolic problems. This is one study in 130 patients. They looked at the HOMA, and you can see as the patients lose weight that you get a significant improvement. This is after 6 months treatment. Here's another study. It's a very small group, only 6 patients versus 12 controls. And again, you see after balloon treatment that there is an improvement of HbA1c, as you can see on the panel here. Big advantage of the balloon is, of course, that it has a very low risk. And again, this is a study on balloons, 119 patients, but there were only 28 diabetics in this study. And these are only the results of the diabetics. And you can see that these patients do have a significant improvement of their HbA1c after 6 months of treatment, with a BMI loss of about 45%, excess weight loss. Well, most of the endoscopic procedures involve endoscopic placation. And there, of course, the tools are getting much better. But also for this group, there are no long-term results. Apparently the newer techniques appear to be effective, but we still have to wait for the long-term results, and we all know from the old Mason procedures and all other types of restrictive type procedures that they do not last in time. And in fact, there are no published data on type 2 diabetes, but of course you can expect that when there's a significant weight losses in any procedure that it will have an effect on diabetes as well. Here are some of the newer techniques, the POSE, primary obesity surgery, and the luminal, with new types of tags to keep the sutures in place. Good 1 year results, 45% excess weight loss. The TRIM, transoral gastric volume reduction, quite similar procedure. You see some pictures from that. And these are slides given kindly to me by Dr. Galvao with the Apollo technique, and these are the results on endoscopy or on fluoroscopy, and you can see that it's quite similar to a sleeve resection. But as I said, no studies that really looked at the metabolic effects, so there's a lot of work to be done there. And this I just show because it shows some really spectacular results on weight loss. There's no published data on it yet. It's the so-called full sense device. It's a stent that you place in the gastroesophageal junction, part in the esophagus, part in the stomach, and it's kept in place with sutures. They were placed initially laparoscopically, sutures here at the his angle. Now they can do that endoscopically as well. And when you look at the results, this is, and I have to look at the slide. This is only after 45 days of treatment in patients, and you have a spectacular weight loss, like the patient is completely starved, and these are even 75% excess weight loss after 6 months, and the problem is that now they have to take the device out, otherwise the patient will keep losing weight, and they are improving the technique, and maybe this is a new future option for real weight loss. What we do have a lot of data on is the endobarrier, and we heard some of that already this morning. The endobarrier is a sleeve of about 60 centimeters, which is kept in place with an anchor, and that anchor is the most important part of the device. It has been improved over years, and now the device is stable for about 1 year treatment. What you do is mimic a part of the gastric bypass. You bypass the duodenum and a part of the jejunum by the food passing through the sleeve and the bile and pancreatic juices passing on the outside. And it's also easy to retrieve. You can collapse the anchor with a special device and then pull it out. And in general, that's only a 10-minute or less procedure. To date, there have been more than 800 patients in several trials, and there are now also commercial application of the device, but I'll only talk about some study results. This is the weight loss that you can find in a 1-year treatment, where about 70% of the patients will be able to keep the device in for 1 year, and when you take it out, they will maintain their weight for several months before they start regaining their weight. But this is more interesting data. This is a study from Chile looking at diabetic patients, in total 22 subjects, and they looked at HbA1c and weight loss and also some other parameters like lipids, but I'll only show the effect on the HbA1c, and you can see that there's a significant reduction of the HbA1c in all patients with a mean implantation duration of about 42 weeks, and a group of 13 patients had reached in the 1 year, and they all got an HbA1c below 6.6. Here you can see some effect on the lipids, which improve significantly, and glucose and insulin levels as well. And again, after removal of the device, you can see that in it's only a small subgroup of the patients, only 9, but you can see that they maintain their low HbA1c for at least another 6 months after removal. Now, these are data from our own study. We did a multi-center randomized trial with 38 endobarrier patients for the 39 diet controls. This is the 6 months data with 6 months follow-up, and we looked at type 2 diabetes and obesity. These are the results, and you can see that the control group had quite a significant weight loss and also a quite significant improvement of the HbA1c, but the endobarrier treated group on the same diet and the same control had a significant better weight loss and a significant better improvement of the HbA1c. In the subgroup of these patients, we also looked at a number of parameters. These were the patients that were treated in my hospital in Maastricht and in Heerlen. This is the HbA1c improvement after 6 months treatment. But more, and you can see that there's a rapid improvement of glucose levels in the meal tolerance test that we did. This is before, and this is 1 week and 24 weeks after treatment. And you see that there's not really a change in insulin response. So we may be looking at change of insulin sensitivity, but as you can see, there is also a significant improvement, I show that later, of the glucagon levels, which could explain that as well. And similar to what you see after a gastric bypass, this is before treatment, this is 1 week, and 24 weeks after treatment, you have a significant increase in the GLP-1 response, which is not as high, of course, as after a gastric bypass, but it mimics the same type of pattern. There's a little bit of decrease of the GIP, and there's a very significant improvement of glucagon. Glucagon levels are high before the treatment, and they go down to the normal levels at 24 weeks. In all patients, we looked at satiety, and most patients report that they have a increased satiety, and they all have reduced food intake. And we looked also at the PYY, which is also the ileal break, and you can see that after placement of the sleeve that there's a significant increase of the PYY response. We had also a little bit of increase of ghrelin, although the patients didn't have much more hunger, and well, and I think that the data on ghrelin are getting more and more confusing the more data we get. So I can't explain it. And what you see that in time with reducing weight, that there is a significant decrease of leptin, which in general reflects the fat mass. It's a safe procedure. These are some data of the second generation device with a low risk of bleeding. This is 1 out of 224. And there were 2 patients that had a esophagus perforation, both treated conservatively, and they were both technical mistakes by the person implanting and removing the device. And I'm not going into detail, but that could be prevented. Of course, the drawback of the treatment is that you can only treat for up to 1 year now, although in Chile some patients have been successfully keeping the device for up to 2 years now. But that is only in the patient that once it stays in for 1 year, you probably can leave it in longer. But what is also interesting that you can re-implant, and these are also data from Chile again. You can see 1 year treatment, removal of the device. After 1 year, they have some increase of their weight, but when you re-implant, they will lose that weight again and lose probably even a bit more. So in the end, you probably can do a repeat treatment with the endobarrier. So in terms of the endobarrier, I think that when the next part of the slide will come up, it doesn't move anymore. There you go. I think that we can now safely say that the endobarrier is safe and effective. It has significant results in type 2 diabetes. And for one reason or another, the computer does not respond anymore. Time's up. Now it's not electricity, but it is the computer. I don't know why it doesn't move. I think the computer, there. Okay, then we go to the last slide. Well, we've heard this morning already that obesity and type 2 diabetes is a big challenge. We've seen very good results of the surgery, but as Harry Freudenberg told us, there are also risks to take into account. And the endoluminal options, once they get better and more sustainable, are certainly going to be a good option, and probably could be a way to go in the lower BMI, low risk patients. Thank you for your attention.
Thank you very much, Dr. Jan. I would request you to stay back to moderate the panel discussion. I would give us a moment to organize the place.
Okay.
And I would request the panelists to please join on the stage. Dr. Luigi Angresiani, Dr. John Dixon, Dr. Ricardo Cohen, Dr. W.J. Lee, Dr. Shaila Sheikh, Dr. Ahmed Khatani, Dr. Kazama, Dr. Rajkumar, Dr. Reddy, Dr. Bhartia, and Dr. Liang.
I can hit you on the head. Well, it will be very, very crowded here on the stage when everybody is coming up, but let's try. And while everybody is coming here, I'm just going to try and put some slides and some questions for the panel discussion. I think we had a very good number of presentations. We had some discussion, especially when we were talking about what is really the effect of the surgery. Is it weight? Is it incretins? Is it gut hormones? And we will try to bring that into discussion a little bit more. One thing is for sure, we all know that. Can I have the slides up, please? Can you change to the computer again? Just a few seconds. No, he's far away from the. He's afraid for the fight. Ricardo is sitting at the other end, so don't worry. No, there's some more coming up. I really would like to have the slide up. It's just on the laptop, so. It's here. It's here. Ah, there we are. So that was what I was going to say, is that we all have seen and heard that surgery is a very good treatment for type 2 diabetes, and Mufi is one of the pioneers here in India, Asia, and especially, of course, in the lower BMI patients.
I would like to interrupt for a moment. One of the panelists I was still to invite, Dr. Rajkumar Palniappan, please. I'm sorry to intervene, Dr. Rajkumar. I'm sorry, please.
No,
continue.
don't worry, I'll just go on. Okay, so for the discussion, do we have a reason to consider new guidelines? In fact, the types of procedures that we do are quite the same. I think we need the same type of follow-up. Diet advice, you need this multidisciplinary team. We just heard this morning that you really need your endocrinologist on the team, which is extremely important. So the surgery is the same, but the focus may be different. So I'm not sure that we really need new guidelines, but we may have to adapt, and we can discuss that, of course. The selection criteria, the lower BMI, patients that are going to start to go to insulin therapy, HbA1c levels, as we discussed. And what we don't want is to have some sort of algorithm like Henry Buchwald published some years ago. And this is not the only thing that he published, because you need to do a very complicated calculation in combination with this algorithm to find what kind of solution you have for your patient. So that's not what we want. Well, this slide has been up. BMI, can we use BMI? Well, we all know that there's a big difference between persons, between races, with the Caucasian, which is actually a marathon runner with only 9% fat mass, with the same BMI as the Indian next to him with 20% fat mass. And what do you look at looking at the BMI? But for the moment, BMI, of course, is maybe one of the selection criteria, looking at the sheer numbers of patients that there are in terms of the problem. Should we look at the duration of the treatment? We've seen that. I think this is a very nice slide by Robin Blackstone, where you can see that duration longer than 4 years, and insulin therapy, which is the lowest block in the graph, has a poor outcome of your treatment of diabetes, and the patient have a short duration, don't use insulin yet, have a very good result. And we also heard from the several talks that the lower the BMI, the lower the resolution of the diabetes will be. And we of course need to have very good criteria what to do, what is resolution of remission of diabetes. And which parameters should we use? Ricardo mentioned it already. Should we look at non-alcoholic steatohepatitis as a selection criterion, waist circumference, insulin resistance, and should we look at weight? Because in the end, I think that weight loss is important, and that's the last 2 slides that I want to show. Because when you look at long-term results, this is from Wei-Ji Lee, with a similar weight loss, you have a similar effect on your glucose control, looking at the homeostasis assessment model. And even looking at biliopancreatic diversion, which is probably the best treatment for your diabetes, when you have a similar weight loss, looking at 5-year results, you have the same effect on the diabetes with an adjustable gastric band or biliopancreatic diversion. So weight obviously is very important. And now I think we have to start with the panel discussion. And maybe the first question we should ask is, do we really need a separate new guideline for diabetes, or should we just go on with the current guidelines and adapt them? And may I ask the panel to react to that? We start with Ricardo.
I think, yes, we need different guidelines, because if you separate, I think you're going to speak later on about this, metabolic and bariatric surgery, the outcomes are different. We're looking in diabetes not only to concentrate on weight loss, but we are looking for control of A1C, lipids, blood pressure. That's the bottom line of cardiovascular events. So the outcomes are measured differently. If you look at the last papers published, the last 100 papers published on diabetes, the weight loss, it's secondary because we can achieve metabolic control with some operation or devices in our endobarrier trial and low BMIs with virtually no weight loss. So weight loss is not a parameter of success regarding remission or not. I think we should look for hard points, cardiovascular events. And I know that John will raise his hand and he'll say,
Yeah, I'll
you
give
still
you
don't
the
have
opportunity
this.
now because
So-
you made your point.
Okay. Well, you still don't have this.
You're sitting at both ends, so you. I keep you apart. John, please, your reaction.
Can you hear me? Okay. I think, do we need more guidelines? I think for lower BMI people, we're going to need more data. And I'll tell you why I'm concerned. We heard quite a lot today about the fact that conventional therapy doesn't work. But let me say that the death rate in the developed world anyway with diabetes has plummeted over the recent years. This century, over a 50% reduction. Our treatment is spectacular. People with diabetes are living much longer. And that's part of why we've got so many more diabetics in the developed world. Very different in the developing world, Asia, China, etc. The second point I'd like to make is that we have to be very careful about relationships between BMI and mortality with diabetes. And there's been a series of papers published in the last 12 months that all show, in Asia and elsewhere, that if your body mass index is between 30 and 35, you have the longest life expectancy if you have type 2 diabetes. And unfortunately, that's going to bite us. We have to think, we have to have hard endpoints, not soft endpoints. We have to show we can save lives. And worse than that, we've had the results of that look-ahead study. And the look-ahead study showed it improved hemoglobin A1C, there was improved weight loss, there was lower blood pressure, people felt better, da-da-da-da-da-da-da, but there was no change in hard endpoints. What was the average, the BMI of that group? 25 plus. In fact, if you're on insulin, 27 plus. So lifestyle measures, weight loss, it was doing nothing. We're up against a real problem when we've got to now provide